Interpreting an arterial blood gas is a crucial skill for physicians, nurses, respiratory therapists, and other healthcare personnel. ABG interpretation is especially important in critically ill patients. The following three-step process helps ensure a complete interpretation of every ABG. The objectives of this session are: 1. To identify the indications for acid-base determination. 2. To develop and demonstrate proficiency in calculating acid-base disorders using a systematic approach. 3. To interpret and analyze acid-base chemistries. The components of ABG include the pH, carbon dioxide, bicarbonate, oxygen, and base excess. In this table you will see the normal values and the normal ranges of each ABG components. In pediatrics, the reference ranges of serum bicarbonate vary by age in both males and females. Let's get started with the three-step approach in diagnosing ABG disorders. Step 1. Identify the most apparent disorder. The pH obtained from arterial blood gas should be the first value analyzed upon suspicion of an acid-base disorder. A low blood pH is referred to as an acidemia. Acidemia results when an acid-generating process, known as an acidosis, creates an excess of hydrogen ions. An alkalemia refers to elevated blood pH when an alkalosis is present. Step 2. Apply the formulas to determine if compensation is appropriate. If not, a second disorder coexists. For metabolic acidosis, the formula called Winter formula is: arterial carbon dioxide levels is equals to 1.5 multiplied by the bicarbonate concentration plus 8 plus or minus 2. For metabolic alkalosis, the formula is: arterial carbon dioxide levels is equal to 40 plus 0.7 multiplied by the measured minus the normal bicarbonate concentration. For respiratory acidosis, it is either acute or chronic compensation. In acute cases, the bicarbonate concentration increases by 1 milliequivalent per liter for every 10 millimeters mercury increase in arterial carbon dioxide, while in chronic compensation the bicarbonate concentration increases by 3.5 milliequivalent per L for every 10 millimeters mercury increase in arterial carbon dioxide. For respiratory alkalosis, it is also classified as if it is acute or chronic. For acute compensation, bicarbonate concentration decreases by 2 milliequivalent per liter for every 10 millimeters mercury increase in arterial carbon dioxide. For chronic compensation, the bicarbonate concentration decreases by 5 milliequivalent per liter for every 10 millimeters mercury increase in arterial carbon dioxide. The degree of compensation should be assessed to see if the patient is responding appropriately to their altered pH. In patients with metabolic acidosis, it is important to determine if respiratory compensation is adequate or if the patient has a concurrent respiratory acidosis or alkalosis. If a patient's carbon dioxide level is higher than the range expected from Winter formula, a concomitant respiratory acidosis is present. If a patient's carbon dioxide level is lower than expected, a respiratory alkalosis is also present. Metabolic alkalosis most commonly results from either diuretic use or gastrointestinal losses, such as in vomiting. If the etiology of the alkalosis is unclear from the examination, the urinary chloride concentration may be measured. Gastrointestinal losses are noted to have low urinary chloride levels less than 20 milliequivalent per liter, while patients currently on diuretic therapy present with high urinary chloride levels more than 20 milliequivalent per liter. Respiratory acidosis and respiratory alkalosis can be assessed further to determine if the condition is acute or chronic. Chronic changes in carbon dioxide allow the renal compensatory mechanism more time to adjust bicarbonate and pH accordingly. Compensatory changes do not entirely correct the primary acid-base disorder. If an individual has a primary acidosis, his or her compensatory mechanism will not normalize the pH. An additional acid-base disorder called a mixed acid-base disorder is suggested by the presence of inappropriate compensation. A normal pH in the setting of abnormal bicarbonate and carbon dioxide levels suggests a mixed acid-base disorder. The The changes in pH in mixed acid-base disturbances are as follows. In metabolic acidosis, you have a normal or significantly decreased pH. In metabolic alkalosis, you have a normal or significantly increased pH. In respiratory acidosis, you have a normal or significantly decreased pH. In respiratory alkalosis, you have a normal or significantly increased pH. The mixed disorders include combinations of metabolic disorders. Examples: vomiting-induced metabolic alkalosis with hypovolemia-induced lactic acidosis, combinations of respiratory disorders, such as COPD-related respiratory acidosis with simultaneous opioid-induced hypoventilation, or mixed metabolic and respiratory disorders, such as metabolic acidosis and respiratory alkalosis in salicylate intoxication, among numerous others. Frequently, the patient's clinical presentation suggests the cause of the disturbance, and other laboratory values, for example a urine drug screen, serum metabolic panel, serum osmolarity, are used to guide interpretation of the acid-base disturbance. Step 3. Calculate the anion gap. The normal anion gap is 9 to 16 milliequivalent per liter. Some laboratories use 10 to 14 milliequivalent per liter as the normal range. If the anion gap is more than 20 milliequivalent per liter, high anion gap acidosis is probably present. If the anion gap is more than 30 milliequivalent per liter, high anion gap acidosis is almost certainly present. When a metabolic acidosis is found, the anion gap should be calculated. Metabolic acidosis is divided into anion gap metabolic acidosis and non-anion gap metabolic acidosis. These two categories have different etiologies and treatments. The anion gap represents the unmeasured anions in the blood, which are formed from organic acids that have dissociated in blood. Unmeasured refers to the fact that these anions are not reported in a standard metabolic panel or ABG but are contributing to the acidosis. Let's talk about the sampling site. The radial artery is the preferred sampling site for ABG because it is superficial, easy to palpate and puncture. Also, there are no adjacent nerves or veins that may be injured or accidentally punctured. Other sampling sites such as the brachial and femoral arteries are avoided because both feed large distal networks and neither has collateral circulation. Also, there is a high risk of damaging the veins, nerves and joints in close proximity to the artery. Prior to performing radial artery cannulation for blood gas determination, a modified Allen test should be performed to ensure adequate perfusion by the ulnar artery. Collect. The ABG kit includes a gauge 23 needle or a gauge 23 butterfly, 2 ml syringe with 1000 units per mil of heparin, a cap for the syringe, a plastic bun, local anesthetic, alcohol gel, gauze, sterile gloves, and sharps bin. The use of non-sterile gloves is acceptable, but the puncture site should not be touched after the area is cleaned. When you are ready to take the ABG, hold the wrist in a position of supination and slight extension. Insert the needle at 30 degrees to 45 degrees angle while applying continuous gentle suction with the plunger. Advance the needle until the radial artery is punctured and blood is returned or until resistance is met. The sample is collected using the appropriate syringe. A higher capacity syringe may be difficult to maneuver, and smaller needles can possibly increase the risk of traumatic hemolysis, which would decrease the accuracy of the hemoglobin and potassium values. Once collection is successful, send the specimen to the lab for immediate processing. There you go. Tell me what is wrong in the following videos. This ends the ABG interpretation session. Thank you.